Great. I actually meant to do that before we got started, but that's okay. So this webinar is being recorded, and the slides and recording will be shared with you all and placed on the NCSC website. This webinar aims to, one, provide an overview of the peer-reviewed literature related to extragenital STD screening of MSM, which will be done by Casey Taylor from Colorado today. Additionally, we will have examples from the field of using comprehensive sexual histories to identify which anatomical sites need to be tested, and this will be done by Dr. Ami Multani from Fenway Health. We will then hear an example of successfully incorporating self-collection of pharyngeal and rectal specimens for extragenital STD testing, which will be given by Rachel Howard from Maricopa County, Arizona. And then we'll hear an example of successfully capturing anatomical site of reported chlamydia and gonorrhea cases through surveillance. And that piece will be given by Daniel Daltrey from Vermont. At the end, we will have our Q&A portion where we'll address all of your questions for the presenters. So let's jump right in. Our first speaker today is Casey Taylor. Casey is a disease intervention specialist and regional consultant for the Colorado Department of Public Health and Environment, where she works one-on-one with clients to prevent the spread of sexually transmitted infections and HIV. Her day-to-day activities in Western Colorado include partner services, outreach testing, facilitating STD treatment, and linking clients to sustainable medical care in rural communities. Take it away, Taylor. Sorry, Casey. Casey Taylor.
Thank you. Good morning. Thanks again for joining us. I'm just going to be providing you with a brief overview of extragenital testing within the MSM population. What is extragenital testing? Who benefits from this testing? What our current national recommendations are? And I also want to spend some time discussing a few of the barriers that you may encounter in offering this testing to your patients. So for those of you who aren't currently offering this testing, I want to include a brief definition, which as you can see here is nucleic acid amplification test, or what I'll be referring to as NAT, testing for the detection of chlamydia and gonorrhea from throat and rectal sites. So why the need for extragenital testing within the MSM population? We know that the CDC recommends annual chlamydia screenings for all women under 25, as well as older women with risk factors, but additional recommendations do include annual chlamydia and gonorrhea screenings for all sexually active MSM clients, or more frequently based on their risk. So to be more specific, the CDC recommends chlamydia and gonorrhea NAT testing for MSM who've engaged in insertive or receptive anal sex within the last 12 months. Also recommended is pharyngeal chlamydia testing for any clients who've had receptive oral intercourse within the last 12 months. And interestingly, the CDC currently has no recommendations surrounding pharyngeal chlamydia testing. However, with the combo testing that's currently used, those are testing simultaneously for chlamydia and gonorrhea. So current recommendations state that NAT testing is the preferred test method for both chlamydia and gonorrhea in men, including the collection of rectal and oral pharyngeal specimens. Another point worth mentioning is that first catch urine is preferable for chlamydia and gonorrhea testing in men, and it is equivalent to a urethral swab, which is great news for our patients, as history tells us that a male urethral swabbing is not the most incentivizing reason to come in for testing. So why NAT testing specifically? I would like to highlight two studies in particular. The first one was published in 2008, and it analyzed the sensitivity of cultures versus NATs in detecting chlamydia and gonorrhea. This study compared over 1,100 specimens tested by standard culture and 3 types of NATs. As you can see here, the findings notated that NAT testing resulted in a higher sensitivity in detecting rectal and pharyngeal chlamydia and gonorrhea infections in men. One NAT in particular, the Aptamacombo 2, showed marked sensitivity and specificity in detecting these two infections. The second study contained a much larger sampling of self-identified MSM clients. These samples were collected over a 24-month period across 42 STD clinics. This study brings to light the necessity of extragenital testing within the MSM population. As the chart shows, a vast majority of chlamydia and gonorrhea infections would have been missed and presumably would have remained untreated if clients were only screened by urine sample. As you can see here, over 90% of pharyngeal chlamydia cases, as one example, would have been missed if they were screening by urine alone. Thanks in part to studies like these, the FDA recently cleared 2 NATs for extragenital chlamydia and gonorrhea testing earlier this year. Historically, sites wishing to collect samples had to go through a rigorous validation process, which can be both time-consuming and costly. With FDA clearance, the hope is that extragenital testing will become more easily accessible and more widely advertised for our at-risk clients. So even with FDA clearance, I think it's important to talk about other barriers we may encounter with this type of testing. I spend much of my time speaking directly to medical providers, whether that's one-on-one or in group settings, and these barriers are the ones that we discussed most often. The first is data. Either providers are not aware this type of testing exists, or they have not been informed on its efficacy. Extragenital testing is proving to be an excellent way to capture infections, increase treatment, and ultimately lower our national disease burden. And the more providers we have on board offering this testing, the more successful we would be. Many of the providers I work with here in Colorado are based in a rural or frontier county and are family physicians. They are not a high-volume specialty clinic where sexual history comes up in a typical visit. So discomfort really continues to play a large role in many STIs going undiagnosed. Most of our clients are relying on a provider to tell them if something is wrong, and unless you as a provider are taking a comprehensive risk history, which includes discussing sexual preferences and activities, you very well could be missing an important diagnosis for an at-risk client. Unfortunately, you can't always rely on a patient to offer this sensitive information at a visit, so standardizing your social and medical history intake to include that risk history and sexual history really is key to understanding the testing needs of your clients. And I do understand that providers often feel rushed or have limited time with patients, and this time management issue is also a concern. However, you will find that the more routinely you take your client's sexual history, the more swiftly your assessments can be completed in the long run. A great way to incorporate this into your practice is to review the 8 Ps, which I believe you will actually hear about shortly. So some additional factors to consider with extragenital testing are the patient's barriers to care. As I mentioned before, discomfort discussing sexual history and risk factors can prevent a client from receiving testing and treatment that they need. Many clients are unaware that extragenital testing is an option, and as a first-time patient or at a clinic in a small area, divulging your status as an MSM community member, a sex worker, an injection drug user may be difficult, if not impossible. So our job as providers is to take this burden off of our clients, to be the ones to say the words, ask the questions, and educate our patients to help them assess their own risk and increase their knowledge. And the final and honestly largest barrier for clients is cost. Currently, most insurance companies do not cover STI testing under preventive care and treatment. The cost of the labs will typically go towards meeting a client's deductible. So as an example, an otherwise healthy male client with employer-based insurance can request a screen for chlamydia and gonorrhea and end up going home with a bill for as much as $2,400. This is just not a feasible reality for the vast majority of our clients. Medicaid clients, they do find themselves in a similar situation with coverage allotting them only one comprehensive visit exam annually. So there are a lot of barriers, but they are things that really can be worked out with partnering with community organizations that may help increase access for clients. So barriers aside, studies really do show the benefit of extragenital testing, especially as we witness this rise in STI rates nationally. So with that in mind, I am going to defer to my co-presenters to offer you some more information. Thank you.
Awesome. Thank you, Casey. Just a reminder that you can submit your questions into the chat box for the speakers, and they'll be addressed at the end of the webinar. So our next speaker is Dr. Ami Multani. Dr. Multani is the Medical Director of Infectious Disease at Fenway Health in Boston. Within this role, she oversees HIV, hepatitis, and STD services, general infectious disease, and high-resolution endoscopy care at Fenway Health. Take it away, Dr. Multani.
Thank you so much. I'm very honored actually to be talking to you today. So we're going to talk a little bit about the impact of taking a thorough sexual history on STD testing. So just to start, I wanted to give you a little background on where I work. So Fenway Health is an FQHC in Boston that specializes in the care of sexual and gender minority populations. We currently serve about 34,000 patients, of whom 50% identify as LGBTQ. 2,200 patients are patients living with HIV, and 4,000 patients who identify as transgender. So, again, as I just mentioned, about 50% of our patient population identifies as LGBTQ, and so I just wanted to give you a little breakdown of how our patients identify their sexual orientation broken down further. And so you can see here on the left are queer cis male patients, the majority of whom identify as lesbian, gay, or homosexual. In the middle, you can see our transgender or non-binary patients. And lastly, on the right, queer cis women, of whom 8% identify as lesbian, gay, or homosexual, and 6% identify as bisexual. So again, I just wanted to give you a better sense of our patient population and how they identify their sexual orientation, as this helps us kind of better understand how our providers ask questions pertaining to sexual health. So again, just to delve into this data one last time, wanted to look at our transgender and non-binary patients broken down further by gender. And you'll notice the interesting display of diversity in how patients identified their sexual orientation. So I wanted to take note of the red and yellow bars that we see in each column, which mean that these patients identify as something else or I don't know. And take a moment to consider how would we ask these patients about their sexual partners and preferences if we were doing their sexual screening. So I wanted to start our discussion regarding sexual health with first defining sex and gender. So sex and gender are determinants of health, which are defined as the range of behavioral, biological, socioeconomic, and environmental factors that influence the health status of individuals or populations, and that's adapted from the WHO. So sex and gender are often used interchangeably, but it's important to note that they are actually distinct. So gender is a multidimensional construct consisting of social and cultural distinctions, as I've listed here, whereas sex is a biological difference where we think of anatomy, chromosomes, hormones, genes, etc. So sexual orientation and gender identity are not the same. All people have a sexual orientation and gender identity. However, terminology can vary and how people identify can change. So, for example, a transgender person can be LGB or heterosexual. A lesbian, gay, or bisexual person can be transgender or cisgender, which is a person whose sense of personal identity and gender corresponds to their birth sex. Okay, so let's move on a little bit and talk about sexual orientation. So it can be useful to think about sexual orientation as having three dimensions: identity, behavior, and attraction or desire. For most people, identity, behavior, and attraction align. For example, a woman who is attracted to men has sexual relationships with men and identifies as straight. However, sometimes these dimensions do not align. So an example of this would be a man who identifies as straight, is married to a woman, but feels a strong attraction to men or to both men and women. So it's important to kind of think about these parameters when we're thinking about sexual orientation. So I think this is a really interesting slide. Gender-diverse individuals have a wide range of sexual preferences, and you cannot assume sexuality based on someone's gender identity. Just as many gender-diverse people identify as straight as they do gay or lesbian, bisexual, asexual, pansexual, and queer. So as providers taking care of patients, we simply have to keep up. We have to ask questions, and we have to want to understand how a patient experiences risk and pleasure to be able to better take care of them. So kind of like Casey was alluding to in the last presentation, LGBT individuals face increased risk for HIV and STIs. This is best documented for MSM, who have rates of HIV, syphilis, and gonorrhea that exceed that of the general population. And it's also important to note that trans feminine individuals face a 49-time greater odds of HIV infection compared to all adults. So it's important to realize that stigma and social discrimination can foster unhealthy coping mechanisms, including sexual risk behaviors, and then this can inhibit access to health care and thereby limit opportunities for screening. So if we do have patients who do get into the office, we need to make sure that we are asking questions kind of appropriately. So when I look at this slide, it's important to, like I just said, we need to be asking questions of our patients. And so interestingly enough, studies have shown that clinicians don't often speak with their patients about their sexual health, let alone their sexual orientation or gender identity. And the truth is we need to make it a habit to ask everybody these questions all the time. It'll normalize asking these questions for the provider and for the patient, and that's really of the utmost importance. So let's kind of talk about that a little further. How do we do that? Again, just to review, why do we talk about sexual health? We know it's integral to the person's general health. It's associated with happiness, well-being, and longevity. Sexual function is lifelong, and it does evolve over a lifespan. It can be associated with morbidity or mortality. There is a high prevalence of sexual dysfunction or misfunction or misunderstanding. And important to remember that sexual history and current function can indicate psychiatric or other medical disorders. It can explain other current health problems, for example, abuse, violence, or other STDs. And it can determine the need for primary prevention, so things like immunizations, contraception, and the need for post-exposure prophylaxis or pre-exposure prophylaxis. So when we think about how to take a sexual history, important things to think about are heterogeneity of sexual identity, diverse sexual partnerships and practices, and sensitivity to language that we're using. So when we talk about sex, it's important to start with introductory language that acknowledges and affirms differences in identity, language used by the patient and sexual practices. It can be helpful to start by taking an anatomic inventory, and I've listed an example here. For example, have you had any body modification surgeries? Establish with the patient from the beginning what words you and they are comfortable using. So, for example, saying to the patient, when referring to your genitals, are there specific terms that you use? I typically stick with medical terms, but is there a language or words that you would prefer to use? Definitely let me know. You want to make sure you check in with the patient to make sure that both you and them are on the same understanding of what these terms are. So we want to ask questions to capture diverse sexual behaviors. It's helpful to validate all sexual practices by asking about both high and low risk activities and pleasures. So we don't want to assume that patients are limited to certain kinds of sex based on their gender. We want to ask open-ended questions. So who are you having sex with? What kinds of sex are you engaging in? For example, which body parts of yours touch which body parts of your partner? Are you engaging in sex for pleasure, or do you feel forced in any way? Are you engaging in sex for money, housing, drugs, or any other service? Do you feel safe in your current relationship? Do you feel empowered to tell your partner to use condoms or barrier protection? Are you using any prostheses or toys for sex, and are you sharing them? So important to know what kinds of relationships we're asking our patients about as well. So understanding the basic forms of relationships, including monogamy, open relationships, polyamory, BDSM, and kink. Talking about sexual activities, so our basics that we're talking about during this webinar, oral sex, vaginal sex, anal sex, but think beyond that as well. Think about gender presentation and disclosure. Like I mentioned before, are patients engaging in survival sex? Is there transitioning within an established relationship? Maybe when this patient established care, they were in a close relationship with one partner, but since then they've opened up their relationship and have multiple partners, so it's important to ask these questions. Move on a little here. And so again, we talk a little bit about the 5 Ps, and the CDC has an excellent pamphlet including the 5 Ps that talks about how to obtain a sexual history. I would ask for us to actually talk about the 8 Ps, which also includes preferences, pleasure, and partner violence. So we'll talk a little bit more about that now. So when we're talking about the 8 Ps in a clinical interview, we start with preferences. So do you have preferred language that you use to refer to your body or your genitals? Are you currently sexually active? What kinds of sex do you engage in? We talk about partners. Are you sexually active with one partner or more than one? Are you dating anyone or sexually active? Do you have any outside partners? How would your partners identify themselves in terms of gender? Let's talk about practices. Do you use toys inside your whichever preferred language is used by the patient? So in your genitals or your anus, or do you use them on your partners? Do you have any other types of sex that I haven't asked you about? Protection from STIs. Are there some kinds of sex where you aren't using barrier protection? And if that's the case, why? Have you had a history of STIs in the past? If so, do you remember the site? And pregnancy. Have you considered fertility preservation or banking gametes? Have you thought about having your own biological children or carrying a pregnancy? And when you are having sex, is there any exposure to sperm or chance of pregnancy? Have you considered contraceptive options? So the question here, pleasure, I think is one that providers really have a tough time and often don't ask their patients about. I think providers can be uncomfortable, but I think looking at these examples of questions can really be helpful. So do you feel that you're able to become physically aroused during sex? How satisfied are you with your ability to achieve orgasm? Do you have any pain or discomfort during or after orgasm? Is sex fun for you? Are you having sex for pleasure, or are there other reasons, survival sex or transactional sex? And then lastly, partner abuse. Has anyone ever forced or compelled you to do anything sexually that you did not want to do? Is there any violence in any of your relationship, and do you feel safe at home? So I think this is a really good outline with really great questions that can help us take better care of our patients. So I wanted to close out my presentation just by briefly showing you the HIV and STD tests that have been conducted at Fenway across all 3 of our clinical sites from June of 2017 to June of 2019. You can see in year 2, the rates have increased in year 2 compared to year 1, except for pharyngeal chlamydia. Kind of like Casey was alluding earlier, in 2018, we actually removed pharyngeal chlamydia testing from our routine STD screening options. So that's kind of why we see that decrease. And you can also see the volume at which we've been testing. And then my last slide just looks at the positivity rate of HIV and STIs at Fenway again over the 2 years I mentioned. And the HIV numbers are just a little skewed because these are also including patients who were previously diagnosed with HIV who had repeat testing just as part of routine screening. So that's it with my presentation. Thank you so much.
Thank you. We'll now hear from Rachel Howard on successful extragenital testing integration in Maricopa County, Arizona. Rachel joined the Maricopa County Department of Public Health STD/HIV program as an epidemiologist in the fall of 2016. Her primary function is to compile and analyze STD/HIV case, demographic, and risk data that is then used to drive programmatic decisions and keep community partners informed. Rachel has grown in her role to provide data quality assurance across many data platforms, educate various community groups about STDs and HIV, and also function as both a co-outreach coordinator and the congenital syphilis coordinator for the program. Take it away, Rachel.
Hi, everyone. Thank you so much for having me today. I'm going to give you a perspective on how we've integrated extragenital testing into our community clinic here in Maricopa County, and hopefully we can give you some ideas on how to make this seem feasible for you. Just in general, an overview of Maricopa County. We are an incredibly large county. We have the same geographic size as Vermont. No shade, Daniel. And we have about 60% of the Arizona population here in Maricopa County. Unfortunately, our STD clinic is the only STD-specific clinic in Maricopa County serving that entire population. We have additional community partners who provide low-cost testing, but we are the only STD-specific clinic. When somebody were to visit our clinic, there's really 2 tracks that they can take advantage of, either our express testing track. These are folks who are typically worried but well. They're just like to have regular STD testing, or perhaps there was some sort of encounter that they just want to get checked up on. They will go through our express testing arm and will be provided with chlamydia, gonorrhea, and syphilis testing. We saw just almost 19,000 visits through that arm of the clinic in 2018. The other option is for folks who possibly are contact to a known STD. They have some sort of symptomology, or they want to speak to a provider, and they can go through our provider arm, and they will see a provider for a symptom evaluation, any treatment for any positive tests that they may have had or any exposure that they may have had, as well as the same testing options that you would see in our express testing. And we saw almost 12,000 visits through that arm of the clinic last year. So I'm going to give you a little bit of a timeline. Luckily, like Casey mentioned, because the FDA has approved extragenital testing as of May of this year, hopefully if you are looking to integrate it, your timeline won't be quite so long. But back in June of 2008, we started hearing rumblings about extragenital testing in facilities in California. Being such a large provider for such a massive county, we felt that it was important for us to give the best possible care that we could to our MSM population, and understood that by offering pharyngeal and rectal testing, we were improving that care for them. So we started onboarding the process of doing a provider collected evaluation or validation for both rectal and pharyngeal testing, and both of those were completed in the summer of 2008. We moved forward with provider collected for quite some time, up until about 2014, when we recognized that it was possible for us to have our patients collect our samples, and that gave us some more flexibility at our outreach events, as well as some more flexibility within our clinic. So in 2014, we began a self-collected rectal validation for our MSM population, and we followed it up with a pharyngeal validation in July of 2018, again for MSM population. We saw a lot of success through this extragenital testing, so we decided to expand it out in December of 2018, and we did a self-collected validation in women. And again, like I mentioned, now the provider collected is approved by the FDA, and so it's as simple as finding a lab who will do it for you. And I understand that's not as simple as it sounds. Just an overview of our validation design for our self-collected, if that's something that you're looking to onboard. We are lucky enough to have a lab on site that runs all of our samples for us, so that was definitely a big asset to this process. But essentially, we collected 100 provider-collected samples and matched them with 100 self-collected samples from our patients. We were looking for about 95% agreement to validate. We actually saw an extremely high correlation. We exceeded that 95% between our provider and our self-collected swabs, so it was incredibly successful, which is great. And I've heard this from other groups who have integrated self-collecting as well. We did see a very slightly higher positivity rate in our self-collected group. It was only 1 or 2 tests, but definitely gives us confidence that our patients are able to do the self-collection successfully and that they are going to get a good result, which is very validating. So I wanted to go over our clinic flow. We actually didn't need to make too many changes to our clinic flow in order to integrate this testing, and so I wanted to demonstrate that it can be, integrating it can be a simple process in that aspect. Essentially, a patient will come in for our testing and be directed to either one of our arms, express testing or provider, based off of their needs. They're going to be offered extragenital testing options, and again, this is now offered to all of our patients who come through the door, whether they identify as male, female, or trans. And then they will be provided with the appropriate swabs. In the room, in their exam room, we're going to give them directions to collect those swabs, and then they will be sent to the restroom where we also have directions posted, and I'll show you the directions that we gave and that we post. So we want to ensure that our patients are getting all of the directions that they can possibly have throughout this process so that they're not confused. They will return to the exam room for a blood draw and a sample drop-off, and then we're going to submit those samples to the lab for testing. We did not need to make any large-scale changes to our clinic flow in order to integrate, which was really wonderful. This is an example of the self-collected rectal instructions that are present in both our restrooms and then all of our outreaches when we provide this testing at our outreach events. We used, as a model, we used LA County's validation and their extragenital testing program when we first initiated this process, and we also borrowed our collection instructions from California as well. So if you've seen them before, that is why. And here is the example of our pharyngeal self-collection instructions, again, both posted in the restroom as well as our clinic rooms, and then along with our instructions when we provide outreach events. So I'm going to get into a little bit of the data of what we've seen here. So in 2018, 19% of our Aptima testing was performed on extragenital sites. As Casey mentioned, both the Aptima and the expert testing have been approved by the FDA. We have been working with Aptima for a while, so we stuck with Aptima. We also see a pretty strong correlation between, or not correlation, excuse me, but a strong matching of both oral and rectal samples. We do see a couple more oral samples that are chosen by our patients, but generally patients decide to do both the oral and rectal, which is, again, encouraging that we are providing the services that our patients are looking for. So here we see a breakdown of the infections diagnosed through our extragenital testing, particularly our rectal testing in this case. So in 2018, about 7% of our chlamydia-only infections were detected through rectal testing, and about 16.5% of our gonorrhea-only infections were detected through rectal testing. We do really have good luck with our gonorrhea extragenital testing. We do find a lot of cases, which is great. And similarly, in pharyngeal testing, about 2.1% of our chlamydia-only and about 19% of our gonorrhea-only infections were detected through pharyngeal testing, which again is wonderful. And this slide is really the bread and butter of why we're doing this. So since 2016, about 2,200 individuals had a negative urine test, but tested positive for chlamydia or gonorrhea in an extragenital site. So that is 2,200 individuals who came through our clinic who would not have been diagnosed with chlamydia or gonorrhea had we not provided this extragenital site testing. And that is really a strong consideration when deciding whether or not to onboard a test system similar to this. So, of course, when you're going to be offering new services to your patients, it is not without its challenges. Initially, for us, we did have challenges in designing the initial and executing our initial validation. Again, we were kind of in the beginning stages of extragenital testing becoming integrated into public health sites. That is not a barrier as much anymore, given that FDA approval, again, which is awesome. And then finding a best practice model for that particular time period to get everybody on board and comfortable with what we wanted to do. We all knew that this was something that was necessary for our community, that this was a very good service that we wanted to provide, but ensuring that we were doing it in a way that made staff here as well as our patients comfortable was incredibly important to us. So we had issues with staffing outreach with providers prior to our self-collection validation, and that was kind of actually the impetus for us deciding to do self-collection. So it's something to keep in mind if you're thinking of onboarding provider collected first and you're hoping, or you already provide outreach events and you're hoping to provide the service at outreach events. You do have to have a provider come along, which sometimes is difficult. If you're at a day of outreach event, it's going to take staff away from your clinic, so something to consider. And then ensuring communication and directions for the self-collected samples, ensuring that our patients aren't confused when they go to the restroom. They know what they should be doing. They feel comfortable asking questions if they have questions. All of that is incredibly important to us. And so when I spoke to our lab, we were really lucky. They had a very smooth transition for this testing, but the one barrier and challenge that they mentioned was ensuring the correct labeling of samples. So for us, that's as simple as putting an O on one tube and an R on another tube. That can be a conversation you have with the lab that's running your samples. But keeping that in mind when you're doing this planning, there was a little bit of a scramble of us saying, oh, how are we going to label these? We need to ensure that we're actually doing the pharyngeal testing and the pharyngeal and the rectal testing and the rectal. So something to keep in mind. But we have seen a lot of success with this integration. It was a transition for our lab. Luckily, we were already using Aptima testing. There are national labs that do offer extragenital testing if that's something that you're looking to integrate. Quest is one of them, as well as LabCorp. And then having a conversation with any private lab that you're using. If they're using Aptima testing, the testing process is the same as the process that you would use for vaginal or urethral swabbing. So they don't have to change their process at all. They just have to agree to do pharyngeal and rectal. So that was really helpful and simple for us. It provides patients with a customizable testing option based on their potential exposure. We're really giving the patient the opportunity to have a conversation with us about what their risks might be, where they were potentially exposed, and come up with a testing plan that works best for them, which has been really successful for us. We are no longer missing infections that are isolated to extragenital sites. Like I mentioned, and previous presentations have mentioned, these infections can be isolated, and we are missing infections if we're not doing extragenital testing. And so it's incredibly important that we try our hardest to onboard these systems so that we are catching as much of this disease and stopping the spread as much as possible. We have a much better understanding of our population given the integration of this testing, and it provides a more complete context of infection patterns for potential intervention efforts. And we found just a true amount of success with this program. So thank you so much for letting me chat about this, and I'm going to pass it on to Daniel.
Great. Thank you so much, Rachel. Last but not least, we will hear from Daniel Daltrey. Since 2006, Daniel has been the program chief of the HIV, STD, and Hepatitis C program at the Vermont Department of Health. Vermont's HSH program is Integrated Care, Prevention, and Surveillance. He oversees all respective programs. He chairs the statewide community planning group and also performs DIS duties. Here you go, Daniel.
Beautiful. Thank you very much, and nothing like being the anchor after all these folks that went before me. A dastardly task, but hopefully I'll bookend it or bring it together and just sprinkle in some reminders of what my colleagues have already presented to you related to the importance of extragenital testing, particularly among the community of men who have sex with men. As Roxanne might have indicated, Vermont's a little bit smaller, but I would still say we might be smaller, but certainly we're still worth a bit of a probing. And in that spirit, I would like us to probe a little bit further into the importance of extragenital screening, particularly rectal and pharyngeal testing. As was said at the top of the hour, about 1 in 10 gay men and bisexual men with syphilis or rectal gonorrhea acquire HIV within 1 year of their STI diagnosis. So let's think about a perfect storm here, folks. 1 in 10 gay men or bisexual men may have a rectal infection, not know it, and they could be that said individual that would have an infection of HIV within the course of 1 year. If we're not screening, if folks don't know, and I don't think it's common vernacular, though knowledge is increasing, I would like to believe, that you need to get site-specific testing, i.e., no reservoir discriminates, all orifices are at risk if they're involved in sexual play, you should get that area swabbed. And by finding out you have an infection in that area, could be a great indicator or reason to leverage other biomedical resources that could be available to you, such as PrEP. And it's one of the things that I love that we are doing, and I'm sure many other programs across the nation are doing it with DIS too, is that if folks are identified as having a rectal infection and they are men who have sex with men, trying to promote or encourage, screen, assess, link, and refer those individuals to PrEP, because certainly we want to turn the tide on this 1 in 10 infection. Part of the way to turn that tide is to make sure that we are finding the bacteria. How are we going to find the bacteria? Well, we got to test for it, eh? And site-specific testing is one of the ways. So just a little bit more, current policy. What are we seeing? What do we know? As my colleagues have already shared, it's well established that urine screening only, especially within communities of men who have sex with men, is going to miss the mark significantly. One of the statistics that I heard in 2015 was that, among men who have sex with men, we are going to miss greater than 55% of the infections if they do not have site-specific screening. And by the way, this doesn't only apply to men who have sex with men. By one of my colleagues in California, I was given some article or literature that among cisgender women, individuals that are diagnosed or identified as women at birth, and currently identify as women, there is evidence to suggest that at least 25% of infections are missed there by not doing site-specific or rectal screening. But the target here, that the attention of the hour in this presentation is MSM. I was simply trying to highlight no orifice discriminates. If it's involved in sex play, certainly we want to swab it if it is receptive sex. So, at any rate, we know that site-specific testing has to happen, that urine alone can't do the job. The statistic I heard in 2015, which really motivated me to look at our data then that following year and say, Vermont is pretty different. And I was wondering, how does that statistic play out in Vermont? What would I actually see? Also, just on a policy front, part of what we know, again, CDC recommends at least once a year screening for sexually active men who have sex with men. Depending upon the risk, that frequency might go up, be it every 6 months, be it every 3 months. So there are some standards out there. Unfortunately, a bit of an FDA thing, maybe a bit of a money thing. NAT is, the FDA has not entirely cleared the NAT-based testing for sites or extragenital testing, which is a bit of a concern and might make it daunting for areas that have not yet been validated to get these type of testings out in the field. However, as we know, NAT is a superior to culture. Yeah, well, anyway, moving along. So the focus for me is gonorrhea. We have a very small annually reported cases of gonorrhea, and so it's really easy for me to dive in. And so when I looked at our 2016 data, again, here's part of the history. Yes, folks, that is our statewide reported cases of gonorrhea. We've had really small numbers, and so why not just jump on in? Especially because one of the things that I see in here, though our numbers are low, is the disproportionate rate at which men, cisgender men, are impacted. Again, individuals that are born as men and still identify as men, who have sex with other men. And so you see a rise in men. Actually, there was a period in which cisgender men were greater than cisgender women impacted by gonorrhea. But then within the male population, there's an incredible disparity happening that greater than 50% among cisgender males identify as being in a community of men who have sex with men. So all the more reason, back to the statistic at the top of this presentation, 1 in 10 gay men with rectal gonorrhea are at risk for HIV. We have compelling reasons to push further and to explore the impacts here among the community. So knowing that we had this disparity, knowing that statistic that I heard in 2015 about missed diagnoses, I closely monitored all the data in 2016. This was ultimately in response to the health disparity or inequity that we were seeing here in Vermont. It's a problem. And so related to this, 53% of our total gonorrhea cases were among MSM. As identified, 61% of those cases would have been the population that was identified as the population that could contract HIV in the course of the year. One of the things that is cool, maybe you heard this in my rambling at the beginning, but our DIS here, assess, refer, and link individuals diagnosed with gonorrhea that identify as MSM to PrEP. We were able to get 36% of our population onto PrEP. What's really cool is how time has changed. I would say now 36% probably applies to the population that are being diagnosed with gonorrhea that don't know about PrEP or haven't been on PrEP already. So it really, in a short period of time, we've had an incredible flip. A number of individuals are knowledgeable, are accessing PrEP. Our health exchanges here in Vermont work really well to help people of various income levels to be able to access PrEP. It's a beautiful thing. Unfortunately, within our cohort of gonorrhea, 6 of the individuals were diagnosed with HIV. that wasn't at the time of gonorrhea diagnosis. The individuals previously had HIV, but still there was a cohort of our gonorrhea among MSM that were impacted with HIV at the time. So, as we know, the triple dip is incredibly important. It's why we're here today. That's why we're trying to roll it out in our program areas, if not already. And of course, the cherry on top, especially as we're working with men who have sex with men, is also doing testing for HIV, syphilis, or hepatitis C. Yes, hepatitis C can be sexually transmitted. So I loved what my colleague Roxanne had to say about the number of cases that had been missed in Arizona, would have been missed in Arizona had they not implemented this since 2016. In 2016 here in Vermont, what I have to say is we would have missed 97% of our infections of gonorrhea had not a triple dip been done, right? We had 33 cases. Of the 33 cases, 31 of those individuals had negative urines. Thank goodness that multi-site screening was done for these said individuals, right? This information, again, very small project, really small thing to do. You don't have to do this statewide. You don't have to do this citywide. You could base this on one of your highest morbidity reporters of gonorrhea. It doesn't need to be an all or nothing proposition, but monitor the infections that are being reported by a site and by that medical practice, and look site specifically about where those are coming from. And if you aren't seeing targeted screening happening among rectal or pharyngeal, maybe there's work that you can do with that clinical practice to see what is the uptake, what are the barriers related to site-specific screening. When I had this data point happen here in Vermont, it's something that you can't turn back from or look away from. Any provider that I am talking to when we're following up on gonorrhea, I review this statistic if they're not already doing it, and you can be assured that they are wanting to screen all of their populations site-specifically. And there's reason to that. Proof is in the pudding, or the swabbing. So, just in conclusion, to wrap this up, triple dip, just do it. Your morbidity is counting on it, literally. You might be missing cases. If you're not doing it, there could be infection that's happening out there that you're missing if you're not doing it. Remember, dust off the old tenets of the gonorrhea control plan. These things are ever more so important today, especially as we are increasingly concerned about resistance. But I think the gonorrhea control plan also speaks to the heart of why we're doing multi-site testing among men who have sex with men. Because if we test and treat, we want to ensure appropriate access to health care, which means, as my colleague from Fenway Clinic mentioned, you really want the provider to do a thorough inquiry in terms of what does sex look like, how are they sexually active, and what the appropriate test needs to be done. You need to target your screening. I'm not saying anyone that goes in for a basic test should necessarily get all sites swabbed, but know your morbidity, know your trends, know where they are happening, and maybe in certain catchment areas, you want to really ensure that they are hitting hard on multi-site testing. Treat sex partners, obviously engage communities, We all don't have the privilege of having the Folsom Street Fair in our backyard, but, there's a way that we get out into the communities and engage the communities and see what might work best. Maybe it is self-collected swabs, as one of my colleagues had mentioned. Maybe it is at a street fair where you can do it, but engage the communities around the importance of site-specific testing. Absolutely involve medical providers. The more they know, the more they will improve or adopt their practices to make sure that they are meeting the needs of the community. Can't forget about promoting safe sex. I know some folks think that condoms are out, but there's still some wisdom in condoms, and there's a time and place for them to be used. no harm. And there's other ways of promoting reduced sex, as we all know. Again, just to wrap this up, no pun off of promoting safe sex there. To wrap this up, the gonorrhea control plan is not an all or nothing proposition. And trying to get these site-specific tests out into the field, think about your practices, your high reporters, where you would want to really make sure that comprehensive testing is happening and work to make it happen for the needs of your community in your respective project area. Thank you.
Thanks so much, Daniel. One moment. Perfect. So thanks to Daniel and to all of our presenters today. We'll take questions now from the chat box. We have this webinar scheduled until 1:30 p.m. Eastern, so there's plenty of time for questions. Just keep them coming in the chat box. Sherry Gregory asks, I know this webinar is about MSM, but has there been any studies about women and extragenital testing? Can any of you speak to that?
I mentioned it briefly. I can try to dig up that literature that was forwarded to me and send it to you, Sherry. But my wiser and more esteemed colleagues might have something ready at hand. The summation that I got was that, again, in cisgender women, at least 25% of infections were missed.
This is Casey in Colorado, and I was just going to say that the only small thing that I have on hand regarding that is our Denver Health Metro Clinic in Denver. They did a study in 2015 and 2016 where they did extragenital testing with a small batch of their female clients, a little over 800 of them. And what they found was that if they had not done the extragenital testing, they would have actually missed 27% of their gonorrhea infections and 14% of their chlamydia infections in those women. And the only thing to note about that is there was a much higher Medicaid cost for doing those tests on women. It was roughly almost $4,000 in cost to do this for women versus a little under $500 to do it for a similar sized sampling of men. So I think there are studies out there, but they are at this point seem to be more limited than the ones within the MSM community.
Thanks so much. Hi, can you share the data that you were referring to? Is that okay? Or if there's a link, can you post it in the chat box?
Yeah, of course.
Perfect. Thank you. I have a question for you all. So I know that it was brought up that a barrier could be provider discomfort, especially when it comes to comprehensive sexual history taking. I'm especially asking about Fenway, if there were any trainings that you all did or that you all do around provider and, getting them comfortable with taking comprehensive sexual histories. And, the other presenters are welcome to jump in as well. But I know that Fenway, you all do this pretty well there. So I'm wondering if you all had any trainings that you do.
That's a great question. So I will say I've been at Fenway for about 8 years now, and we didn't when we first started, but we do now for all of our providers. They get orientation with how to provide care to our transgender patients, and so how to get a good sexual history is actually incorporated into that orientation.
Awesome. Thank you.
Yeah.
And for the other presenters, do you all do any kind of trainings with providers when it comes to sexual history taking? Just one of their other examples. Mm-hmm.
With the Colorado Department of Public Health, since we do outreach testing and extragenital testing for our at-risk clients, we do try to incorporate some in-house training with our capacity building team, where we are doing, comprehensive sexual history taking, interview skills, cultural sensitivity, those type of things, just so that we, can create that better connection with our clients regardless of what situation they're in.
And we have a similar approach at our Maricopa County Clinic as well for our in-house providers.
Awesome. Thank you so much. We have another question in the chat box. Dara Rosenberg says, is there any guidance regarding encouraging private providers to test extragenital sites? Have any of the speakers or their organizations done community outreach to private providers, and have you encountered any resistance there?
This is Casey again. Sorry, I don't mean to be overtaking the questions, but I will say that that's one thing that we've worked with here in Western Colorado is just increasing that provider knowledge base. So we have occasionally been doing some provider outreach where basically we are meeting with like private clinics or hospital groups and just giving them a better idea of what those STI rates look like in our state as a whole and also locally within their community, and sharing with them that data on extragenital testing and the number of infections that are being missed if we aren't offering this to our clients as needed. And that has, I think, been eye-opening for them to see what it is that they're missing if they aren't providing this currently. But and there hasn't been very much resistance to that. However, the cost issue has been probably the number one barrier that providers have brought up is, that cost to their client and additionally the cost to potentially the clinic itself.
Casey's really killing it. I will add, so we similarly have been doing similar types of education with providers in our community, haven't encountered a lot of resistance, have encountered resistance surrounding price. Luckily, we are able to refer to our clinic if that's something they want to integrate. I also wanted to mention that I think it's helpful to encourage providers to seek out the lab that they're working with and see if they provide this testing. I think occasionally it's just a matter of how do I even get the ball rolling. And now that we have this FDA approval for, this NAT testing, and there's large-scale labs such as Quest and LabCorp that are providing that testing, I think that kind of can knock down that barrier. So encouraging providers to speak to the lab that runs their testing, or even if they have the lab on site, ask them what type of test they run. Because like I mentioned, if they are running the Aptima, I guess I can't speak to the expert, but if they are running the Aptima currently, there's really no change in their testing process, and so it's easier to onboard.
Great. Thank you. Beth says, what is the cost associated with lab-validated testing? Are there mechanisms to cover the cost for uninsured or underinsured clients? Can any of you speak to that in your jurisdiction?
So in our, specifically in Maricopa, all of our testing is under our Maricopa County funding. So we don't necessarily have that exact barrier, but I was at a conference yesterday where we spoke about extragenital testing as well, and there are particular mechanisms in some states that will cover it. I think it's just a matter of finding out if it's covered in your location. I don't think that there's an overarching way to cover it for clients.
Thanks so much. We also have a question from Michael Kaufman. He says, Hologic recently received FDA approval for clinician-collected throat and rectal CT&G testing with their Aptima platform. Are any of you aware of any NAT manufacturer working on FDA approval for self-collected throat and rectal CT&G testing?
Cepheid is, aren't they not?
Yeah, so my understanding is the Aptima test that is approved is the NAT test as well, and I believe the expert test is the NAT test as well.
Gotcha. Thank you. Any other questions? I see some folks are typing, so I'll give you a second. And while folks are typing, I'll go ahead and submit another question as well. Have you all encountered any issues with the self-collection of these swabs? Maybe patients, even with I believe, Casey, you talked about the different signs that are in the bathrooms and everything, but have you encountered any barriers with patients and the self-collection swab? I'm wondering if any have come up for any of you.
I also wanted to mention, I realized that Michael was asking about self-collected. My understanding is the provider-collected is approved, but the self-collected is not. So the self-collected validation that I showed was our kind of workaround for that. As far as barriers are concerned, we've had pretty good luck with, the instructions are fairly simple. We've had pretty good luck with our clients understanding those instructions. The biggest issue that we have is people accidentally, if you've ever seen the Aptima tubes, they have a foil top, and accidentally piercing that top, which invalidates the test. But we really try to hammer that home. And then yesterday when I was in this conference as well, one of our community health resource folks mentioned that if in order to make it more comfortable, the rectal testing more comfortable for folks, that you can have them dip it in the transport solution that's in the tube and then insert it so they don't have to insert a dry swab. So that's a fun little tip that I thought was worth sharing. But we haven't really had many issues with the self-collection as far as misunderstanding instructions or, like I said, we actually saw a slightly higher positivity rate when we did our validation. People tend to be pretty thorough.
And I would just echo that here in Colorado that currently all of my extragenital testing is in a non-clinical setting. So all of my specimens are, the rectal specimens are self-collected. And I've found that in some ways really, I think, increases the client's comfort during the session to be able to say, this is the instruction, this is what you do. If you have questions, I'm happy to answer those, but this is something that you can do alone. We just met, so we don't have to be that close during this session. So this is what you do, and then you can come back, and then I'll explain the rest of the process to you. And I found that most clients are very agreeable to being able to do that alone.
Great, thank you. I did want to take a step back just to make sure that we answered Michael's question. I believe one of you may have answered it. I just want to make a clarification. So he was saying his question was referring to FDA approval for self-collected versus clinician-collected. And you also said there's approval for clinician-collected, but not self-collected. Is that correct?
That's my understanding, yes.
Okay. Just making sure. All right.
I think there's a really large precedent for self-collected, though. So if that's something that you have concerns about onboarding, Casey's obviously has onboarded it. We've onboarded it here. There's many sites in California that have onboarded it. So there's really large precedent. If that's something that you're looking for a model, they're definitely out there.
Great, thank you. Any other questions for the chat box for the presenters? I'll give you all a second if you want to type in there. Okay, and if there aren't any other questions, I'll go ahead and wrap us up. So thanks, everyone, for joining today, and thanks again to our great speakers for their time and their contributions to this webinar. Everyone's contact information, including myself at NCSD, are listed on this slide in case you want to reach out with other questions. Please complete the evaluation after the webinar ends. This will help to inform future webinars of the MSM Advisory Committee here at NCSD. The recording of this webinar and the slides will be sent out to all those who registered, and it will also be posted on the NCSD website. So with that, I hope you all have a wonderful day, and thank you so much.